So I was asked, along with my colleague Dr. Beatrice Lupsa from Yale University, to author the paper in the special edition of Diabetologia focusing on the risks and benefits of the SGLT2 inhibitors. Both Dr. Lupsa and I have been interested in this drug class for many years, and there's obviously a lot of excitement about the SGLT2 inhibitors because they were the first drug class to demonstrate a clear cardiovascular benefit in high-risk patients with type 2 diabetes. In the EMPA-REG outcome trial, the trial that I was involved with, empagliflozin, an SGLT2 inhibitor, reduced cardiovascular mortality by 38% and reduced the heart failure hospitalization rate by 35%. So that was a dramatic finding because never before had there been any such benefits on the cardiovascular endpoints from glucose-lowering medications. And that's been subsequently confirmed by other trials such as CANVAS with canagliflozin. In addition, because they're glucose-lowering drug, obviously the hemoglobin A1C decreases, but it's interesting, these are not powerful glucose-lowering medications, so the hemoglobin A1C on average is reduced by perhaps 0.7 to 0.9%, despite the fact that there are these huge benefits on the cardiovascular system. The other benefit that we found in the EMPA-REG outcome trial, also confirmed in CANVAS, was a reduction in the progression of chronic kidney disease, another very important complication in patients with diabetes. Now, like any medication that we use in type 2 diabetes, there are pluses and minuses, and we spent a fair amount of time in the paper discussing the risks and adverse effects of this drug class. First off, patients will clearly experience an increase in urination. This can be somewhat problematic in older men if they suffer from benign prostatic hypertrophy. They can appreciate an increase in their urinary frequency. Because there is now new glucose in the urine, this can increase the risk of genitourinary infections. And I think that is the most commonly increased adverse effect from the SGLT2 inhibitors. These are typically genital mycotic infections, not so much urinary tract infections. Some patients can become volume contracted with the SGLT2 inhibitors, and if they're predisposed to dizziness or even presyncope, that can also occur. More recently, there's been this discovery of diabetic ketoacidosis, or DKA. Now, this initially arose in the experience with this drug class in type 1 diabetes. They're not approved for type 1 diabetes, but there's been some off-label use, and in clinical trials, several of the compounds have been tested in patients with type 1 diabetes. So the reason for the DKA is not quite clear. It could be related to an increase in lipolysis that occurs when using the SGLT2 inhibitors. The rates can approach 10% in patients who have type 1 diabetes, so I think that's an appreciable concern that is kind of dissuaded the enthusiasm for using these drugs in patients with type 1 diabetes. In type 2, the risk is probably on the order of 2 per 1,000. So it's there, it's low level, and I think we just need to be aware of it. Interestingly, the DKA can be euglycemic, or at least not as hyperglycemic as routine DKA, and that can delay the identification of patients with this condition. More recently, from the CANVAS program with canagliflozin, 2 additional potential adverse effects were demonstrated. The first was an increase in fracture rates on the order of about 25% or so. That is a 25% increase in the relative risk. There was a doubling, however, in amputations, and this is a potential side effect of canagliflozin and perhaps the SGLT2 inhibitors as a class that deserves a lot of recognition from practicing clinicians. We would not recommend using the drug class in patients that have had amputations before or have advanced peripheral arterial disease. Interestingly, in the EMPA-REG outcome trial, we looked back and could not find any signal for increased amputations in those patients that were randomized to empagliflozin. So it may be specific to canagliflozin, but I think we just need to wait a few more years, a couple of more studies before we have any certainty that this is not necessarily a class effect. So in summary, the drug class is exciting because of the reductions in cardiovascular as well as renal outcomes for the first time in type 2 diabetes. But as with any medication, as mentioned, there are going to be some adverse effects, and I think clinicians just need to be aware about them.